Yesterday, you guys had a wonderful talk on data governance. I doubt I can do better than that in any practical terms whatsoever, in terms of realizing what you can and cannot do with your data. Instead, what I will focus on in my talk are the complications that are occurring at the intersection of the genomic and IT revolution, and whether we need a new way of thinking about data, and whether the current strict standards on what you can share, can't share, can be better in a different world that is very data hungry and demanding. As a starting point, I would like to point out that, at least to me, when we speak of the word digital health, it is not at all about conventional health delivered by digital means, or even the use of AI to supplement conventional methods of healthcare, but a complete reimagination of what health would mean in a world where the genomic revolution has occurred, which basically means that wellness, as opposed to disease, will increasingly become part of what we consider health. And the type of things I talked about in the morning, digital twins, promoting wellness, maintaining a watch, may be occurring with you as you grow older, well before there is a disease demand. So when I spoke in the morning about digital twins, I was imagining a scenario where the questions are, how do I manage the disease better? But if you look at the future of digital health in the way it is defined by Paul Sonnier, it will mean something that is continuous from the time virtually that you are born, may include your genomes, may include a variety of things, may include your activity levels. So everybody is a patient in this sense of the word. And in some ways, it's captured by the fundamental point we all know: we are all dying, just at different rates. So the future of health is really about making sure the rate is slower and health is optimized as long as it can. So many people use the word P6 medicine. The P4 is very common: to predict, to prevent, to personalize, to participate. This last word, participate, is why I come back to the data. Everybody knows that P4 health will not happen without a strong participatory mode from a very large number of people. And I gave you some examples about people like me or patients like me earlier in the day. So this two more P's have been now added. One is psychosocial and one is public health. I want to bring your attention to this paper that came out, I think, around 2014, a glimpse of the next 100 years in medicine in the New England Journal. And what I want you to see is what they say: everybody is focused on the devices and the types of data that we can generate. But the real quantum leaps will not come from the devices, but rather from the inferences drawn from the data. And at the risk of repeating what's already on the screen, the size and complexity of this characterization of patients will lead to far more complex diagnostic and prognostic categories than are currently in use. But this is the main part. You will have formulas useful for clinical purposes that we can't really explain in language. The average doctor is not known for their interest in medicine because of their love of data or formulas. And yet we are saying the future of medicine will be about people using formulas difficult to summarize for anyone. And yet this is the way healthcare would be. And I spoke to you earlier about mechanistic understanding, but at the end of the day, if your ECG predicts something that you don't understand, but predicts it really well, and you validate it in your population, you can build a lot of safeguards. The reality is you are going to have to use these things as far as they can. And the only real safeguard that one can build is to make sure the right data was used while building these algorithms. Already, for example, in skin disease, it is very well known that it's very easy to predict skin disease from pictures, and people have done fantastic jobs about it. But almost all the data is on white skin. Take something as simple as vitiligo. It's very obvious to you that a disease that makes you lose pigment would look extremely different on a black skin compared to a white skin, and shades in between. Change it to things that change the pigmentation to reddish and things like this. Again, looks very different on a white skin versus a darker skin. And the reality is something could function great. We don't understand how it functions. If it's only trained on data from one part of the world, you will have a bias against the other part of the world as you bring that in. So as we build data sharing architectures, we have to worry about two sides. On one side, we have to worry about what's called data colonialism, in which cheap data, valuable data cheaply taken from low middle income countries, goes to higher income countries, becomes a product like these algorithms, and comes back to the low middle income countries at an unaffordable price. It will be reminiscent of many things that have happened in history, and you want to safeguard against it. The same principles have previously come for biodiversity exploitation and so on. But on the other hand, you have to worry that if you were to protect your data so hard that nobody can use it easily, then you never get any algorithms for use in your populations, irrespective of anything else. So finding that middle path where restrictions are not so onerous that innovation stops locally, while they are sufficient to prevent data colonialism, is what you're really looking at. A principle I will speak about now because it's more of a philosophical principle. If you raise a wall, there will always be some cost, some ability to jump over it. By creating a high wall, you might make sure only the rich, most powerful companies can jump over it, while your local innovators can't. And I would like to say at the outset, and if there are any thoughts, we can even discuss them now, because I only have 20-25 slides here. Take informed consent. You give consent every day you open an app on your phones. Half the time you never even read about it. You want the app, you give the consent, you say it's okay. So the ability to get consent is proportional. Well, proportional is the wrong mathematical word, and we have mathematicians here. Is dependent upon the ability to give lollipops to people. Those people who can give a nice shiny thing and a lollipop will get the consent fast. A person who can't get it easily. So consent in itself is not necessarily the solution. A philosophical point as I will go forward. So let's start with something that troubles me the most, which is genomic. And this is not just a question of the fact that genomic data cannot be de-identified, which is already a discussion we had yesterday. Wonderful answers came from Nikki. The point is something else. If you were to imagine the future of health, you will come to the conclusion that in the version, at some point in the future, people will be sequenced as they are born to identify any possible immediate risk that need to be taken care of. Now let's take a very hypothetical case, and we'll come back to this case in the discussion at the end to see what we have learned. A young girl, for whatever reason, is sequenced at birth. A mutation is found in a BRCA gene that increases her odds of breast cancer by about 3-fold. Let me give you some background information. The risk of a woman today who does not die of a heart attack or of an infection, of developing breast cancer at some point in her life, is in the range of 20%. Now, percentages and odds don't convert exactly, but I can tell you that if we were to use odds of around 3, this person is more likely than not, given the BRCA mutation, to develop breast cancer in their lifetime. Now, once you rephrase the problem like this, you have a young girl who is more likely than not to develop a significant breast cancer event in their life. It's information worth knowing, right? It is actionable information. I will not necessarily argue the point of whether what Angelina Jolie did was right or wrong, but as a quick estimate, the mutations she had, the history she had, her risk of developing ovarian or breast cancer, now there's an or in the middle, so probability rises, was around 75%. At a 75% probability, having completed your family to get the organs removed to reduce your chances is an eminently sensible decision for those who can afford it. I can think of plenty of people in India that I know who are already going to Memorial Sloan Kettering to do things like this. This has become standard of care in America. But let's come back to this baby. Clearly, somebody needs to know. The baby will not benefit by knowing. Even if you change the word baby to a 14-year-old girl, is there a benefit to knowing? None. What's the benefit of telling the patient's parents? Not very clear. I mean, by the time 15, 20 years have passed, the parents may be there, may not be there. What's the benefit of simply informing the doctor? Well, the doctor could change. I mean, you go from a pediatrician, adult doctor, who's going to transmit the information? My point is, imagine an ideal medical system in your mind. This data, no matter how private, must be shared with somebody, no? It must be shared with somebody so that it remains actionable. This is not the same data sharing we talked about yesterday for research. It's about who all should have access to this data going forward. It is very much within the domain of healthcare. So many research ethical problems don't apply, but the architecture of the healthcare system does apply. And we'll not get to this question. My point is we can dispute this all we want. The reality is all these questions have come before. Should people be screened for multiple possible heritable disorders at birth? Now they are. There is no question of whether they should be or they shouldn't be. Will there be a stigma attached to them? It doesn't matter anymore. They are. In the end, given enough time, you will see sequencing occur, starting very early in life. So why governance? And now I'm expanding the case to not only the healthcare system, but everybody who may want access to the data. The reason is the reality. And sometimes Dilbert captures the reality of our world far better than we can articulate it. So I'm not going to bother to read out this particular cartoon, except the last line. Not everybody who wants access to the data actually cares about the health of the person whose data they are taking. That's another reality. So this is something, this entire digital health ecosystem that we are imagining will be grounded in the users and their data. And here I'm going to take a very short side road to explain the basis of my thinking as I come towards the end. So this will be a little bit of background that may help you in the discussions. And this comes from two things I've been part of. One is a Lancet Financial Times Commission governing Health Futures 2030. We included the Financial Times in this commission because the private sector is as much a party to this thinking as anybody else. They are the ones driving a lot of the innovation that is happening currently. And the other is a digital transformation for health lab, of which Ashoka is a part, and there are multiple centers globally. It continues the work of the commission. So a little bit about the commission. The idea of the commission was to deliver recommendations on the governance of all these topics: digital health in general, AI, universal healthcare, along the lines of what I had said earlier. When it comes to AI health, there is only one senior partner, that is health. It was a reasonably diverse group, and don't go by the fact that they're all older. We had enough number of youth commissioners representing the interests of young people. And for those of you interested, there is a special issue of the Lancet covering the findings. I'm going to summarize the key things we thought about. You can either ground your thinking in rules. That's one way. So many rules and acts have been passed, you can ground them in that. Or you can say that all acts, all rules, all laws are temporary until the next one comes along. In which case, what you should be thinking about is what are the value frameworks for governing health futures in which policies will be made in the future. Until GDPR came, there was something else. After GDPR, there will be something else. Same with the Indian thing. It is best sometimes outside the practical, pragmatic domain, which is what you do today, or what you want to see as the ecosystem for the future. The second important thing we thought about was digital determinants of health. If we were to believe that digital will be important in health, then digital will also become a determinant of health. That's relatively obvious. And digital determinants of health are important because when we imagine the ecosystem of the future, are we also thinking about access to people? When we imagine that the Indian Digital Privacy Act will allow people to access and request changes and corrections to their data, are we imagining how many people will have that kind of digital access? Even when we say that smartphones are there in every house of India, do we ask whether a young girl of the house has as much access as the senior older male member? So many of these questions need to be asked in digital determinants. And last thing is putting young people at center. This is important because our thinking for health is very disease-centric. Disease is what worries older people. If you were to ask young people regarding what health means to them, and I'm not saying they're right, I'm simply saying everybody has different priorities. You will not hear diabetes, cancer, and things like this. Adolescence is a very interesting time. Those with serious diseases have already died or had something occur. Age diseases have not yet come. So actually, when we surveyed it, the most important priorities to those people, anybody want to guess? What was the number one priority for young people in health? Guesses? Mental health, wellness, sense of well-being. Number two, sexual health. Number three, fitness. None of these are conventionally described as part of healthcare itself. You ask them, what do you care about? And actually, fourth one, which was interesting to me, was identity. I'm not even sure how exactly identity becomes a health problem. But if you were to ask people, young people will say identity is a very major part of their issues when they think about the digital world and how they exist in it. I'm not the one who dug deeper into it, but apparently for many people, the ability to have a persona online is one of the biggest escapes from mental health in life. They can be who they want to be. And it's going to be very amazing when the genuine AR, VR world comes in, how this occurs. I mean, I'm not young enough to think through this properly, but it's interesting. So recommendations that we gave is address the role of digital technologies as determinants. We'll speak a bit more about this governance architecture that fosters trust. If young people will be using all these things and generating data, then a trusted architecture is going to be critical. So we'll talk about trust. And govern health data to increase public value. It is less about how to protect it so nobody can use it in an unauthorized way. For those of you who know Hindi, there is, and I'll translate it, there's a quotation, Tale, choron ke liye nahi hote, sahukar ki khushi ke liye hote, which basically means locks are designed for the happiness of the people who have something to keep. The thieves anyway know how to break locks, they know how to train it. So trying to say data is secured by this means or that means has very little deterrent effect to the true malactors. What becomes a big deterrent to people who might want legitimate use but can't cross all the hurdles that you put before them. Malactors continue the way they are. And last is to invest in enablers for digital transformation. I'm going to skip on this one, except just let it be that you must think of digital technologies as a determinant of health and access and all those things when you think about the future of AI and health. And instead, I'm going to focus on this. So where do we need more strength? We need strength on the policies that govern if harm occurs. How to protect people, not so much on how to hide the data. Assume for a second that whatever you do, somebody will counter do. Focus on this. Stronger policies and laws on human rights, including rights, to protect against harm. If you can show harm, you can show responsibility, there must be strict actions. That is where investing time in governance and regulation is better said than on data architectures. Number two, increase engagement. The more engaged people are, the more that vision of participatory growth of P6 health will occur. And rightful, correct use will get promoted in the community. And you must remember something. People said, why do you rob banks? That's where the money is, right? Why do people want to break data? Because if you see this as a gold mine that you're breaking into. But if data was easily available to all in a way that protected people against harm, the incentives for maluse would actually drop. And of course, fight against disinformation. This is particularly important for children. We won't get into it today. So this is, I'm going to skip past. And this is a word that I'm going to come to again and again, and I'll give you some examples of how we are thinking about it. So what we came up with was that data solidarity should be the key principle. And I'm going to discuss what it means a bit later, but the basic idea is, if you start by saying, we know it can be misused, we know harm is possible, we know perfect protection is not there, but we know there is tremendous benefit, what middle path that every party understands and is acceptable to all in the larger vision of the larger good can we create? Knowing there is a potential for harm. There is no point in saying in an ethical form, we have made sure there will not be any harm. You can't. Nobody can actually say that. And hold people responsible for this. So this again, and I'm going to skip past this particular one and come to this particular reason. So basically today we talked about, responsible ethics and restriction, protecting individuals, but we need equity. And that's the example I was giving you about dermatology and things like that. This is two very important principles of data. Everybody talks about who owns the data. And very often guidelines come and they say people own their own data. Let me tell you why in the genomic world that makes no sense. If I got myself sequenced, what is the value of a sequence in isolation? Absolutely none. When I get myself sequenced, I have an expectation that my sequence will be compared to hundreds of other thousands of sequences and data so that I get information regarding my risk. It's very unlike many other medical tests, right? There is no value to a sequence in itself except in relation to many other sequences. So which also means my sense I own my genetic sequence, when the only value I got out of my sequence was in relation to other people's sequences, is incorrect. There are two concepts in ownership which are called excludability and rivalry. Excludability means the ability to prevent a non-paying user to not use something, right? You have a flat. You want to prevent somebody who does not pay you rent from using it. Well, that's very excludable. You can just put a lock on it, or you can use law to help you. Locks of 4 can be broken. The second concept that comes is rivalry. It's important because two people cannot live in the same room at the same time and use it the same way. Now think about data. Data is very difficult to exclude people compared to, say, a physical asset. Also, it is non-rival. There is absolutely no problem with the same data being used by tens of people at the same time without compromising the ability of one to use it fully. So data is neither easy to exclude and nor is it rival. So which means the typical idea of private ownership doesn't apply as well to data as we think. So when we talk about data being the new oil and the value of our data, we being the owners of our data, it actually makes very little sense to many people thinking about it. All that we really want is our data should not be used to harm us. That we can all agree on. So principles of privacy and limitation on use such that we are not harmed and we perhaps get to share in the benefits. And share in the benefits, again, is a very interesting word that we'll expand on, is an appropriate one. So governance principles should not be about trying to declare ownership of the data or spend a huge amount of paper space in saying data belongs to the individual. The principle should be about promoting sharing for allowed use while limiting privacy breach and misuse. This is simply a starting point. If you take a different starting point, you will end somewhere else. If you were to agree that this is what governance principles should be based on, you will next come to the conclusion that we must make data easy to share, but also, strictly try to penalize misuse. So this is basically the type of access, and Barbara Peinsack in Austria, University of Austria, is one of the leading thinkers in this space, where she speaks about data solidarity, a blueprint for governing health futures. She was an advisor to the commission and is a very valuable member of the new digital transformation for health lab. Even the name is chosen. Digital transformation of health is a given. Health will not remain untouched from digital transformation. The only thing to care about is digital transformation for health. So there are two things: low public value, high public value, low risk and high risk, right? And for each of these, she has put a type of a thinking place that you can use for how to share such data. Let's take this one: low public value and high risk. You simply should not allow data use for this type of thing. That is the best place to put your maximum restrictions. There is minimal value that you can see. Just because a researcher is interested is not sufficient grounds. Interest is not good enough grounds in a solidarity-based system. It's not about academia. It's about solidarity for a purpose. If there is no clear purpose, there is low public value and there is high risk, you may choose to put very, very stringent recommendations in this particular place. If there is low risk and low public value, you may also consider that people who are sharing their data are getting some risk, while the public is not getting much value out of it. So perhaps an incentivization through profit sharing or something like that may be appropriate. None of these are hard and fast. It's simply a framework of thinking. This high public value and low risk, as long as basic harm mitigation instruments are in place, you should encourage and support the use of such data, as less restrictions as possible. And of course, this last category, you need to think more about risk mitigation because it is high risk and high value. And we will now come to some specific thoughts on this, but this is just a framework for how to organize thinking. It is very different from current data privacy acts and models that treat almost all personal data exactly the same way, not recognizing this kind of a distribution. Problem with acts is they have to be written in a law, and law cannot be ambiguous, and this is ambiguous. So I fully recognize the problems. But as we go forward, perhaps we will have sections of the act pertaining to different types of use cases and examples, and people would have to justify how they perceive the data set they're talking about. So where is genomic data? I would say public value is indisputable. I don't think we even need to think about it. If you imagine the future of genomics, the public value is indisputable. Risk is high. And the risk is a very interesting risk. It's not only to you, it's to all people who share your ancestry. I'll tell you a very practical challenge that we faced in my former Genomics Institute. We found that a community was particularly high risk for a particular disease. And since it was my own, I have no problem in stating it. So a last name of Agrawal makes you high risk for spinocerebellar ataxia type 12. It is rampant in the Bania community, particularly towards Uttar Pradesh. Now, if we were to disclose, it's very useful for a doctor every time they see an Agrawal patient or a name that corresponds to Agrawal that most of us in India would recognize. You know that Ansal, Bansal, Kansal, Gupta, they're all Agrawals. So the doctor will immediately start thinking the minute they see any cerebellar signs of SCA12. On the other hand, it could stigmatize communities. Do you release this information? Do you not? In the end, we decided to release it. And there are no, I could easily go the other way around. If we had decided not to release it, I could have defended that as well. But the practical choice is this was something worth knowing. Because, for example, in Ashkenazi Jews, knowledge about Tay-Sachs disease led to the beginning of a program that led to elimination of the disease. So because these paths are possible, it is better to let the community know, but with engagement from the leaders of the communities to minimize possible stigmatization, and while making sure that appropriate testing facilities are made available at very low cost. So what my institution did, it worked with Lal Path Labs to create very affordable, simple PCR tests that were made available for neurodiagnostics. We ran a program called GoMed that did the testing for free for people who absolutely could not pay. And we announced the risks. And again, there is no hard and fast right answer. This is what we thought was mitigation. So testing is easily available, and in the end, the community benefits. But all of this was done in discussion with other stakeholders, not unilaterally, based on two researchers speaking to each other. And that's something I think that was also brought out very nicely yesterday. Patients themselves will have views, and was for consent, I think, Nikki, you said that, talk to them. That remains the simplest mantra there is. Talk to people, don't imagine what they think. And in genomics, it's very important. And this question, are mitigation strategies in place? In genomic diseases, they are. IVF can be used, embryo selection can be used, genetic compatibility during marriage can be used, many things can be done. So genomic data is the type of data that must be shared. Risk is high. One must think about it. And the simplest mitigation strategies do not allow entire genomes to be downloaded. Almost everything you want to do in genomics can be done without owning individual genomic data. I'll give you an interesting example that sounds like a good story, but also it has a undercurrent. A person in Florida was caught for a murder because of interesting genomic information in the public domain. So what it turned out is he left DNA on the crime site. The DNA did not match a known criminal. But America has these very interesting genetic ancestry sites where people have deposited a lot of their data. So a person who was likely to be a first cousin, data was available on the ancestry site in the public domain. So now it was a backward calculation. You know that this person is likely a first cousin of the perpetrator. Choose all cousins that you can find about that person. Choose which ones of them were there in Florida. Choose from mobile data that the law authorities can get who was near the crime site on that day, and bingo, you have your murderer. It sounds like a wonderful story. Change the word murderer to revolutionary. Change it to somebody who was protesting against the government on XYZ, and suddenly the story doesn't sound as nice anymore. But the fact is that genomic data in its entire sequence can be used to break identities. If you have an uncommon last name, from your genome sequence alone and a zip code, one can figure out pretty much to the level of your house. That's how interesting it is. So if you're an Icelander type of a DNA, the number of Icelanders in America aren't that many. We have your zip code, we can probably get down to your house or your neighbors. So the Global Alliance for Genomic and Health, it recognizes that the benefit of genomics are global, but the practices might harm people and communities. So the entire idea is federated learning architectures. Don't get to look at the individual sequence of a person. Shuffling can be done, and that's the kind of stuff that was also discussed. But shuffling in genomic exercises can lead to some other distortions of genomic studies, so people don't like to do it. But a pure federated algorithm is good. And the nice part, unlike clinical data, is everybody stores genomes in exactly the same format. They're like the DICOMs. Everybody knows the file structure. So since you know the file structure, it is quite easy to implement federated architectures in genomics. And of course, all these four words are very important. Even if you have followed all the practices in every specific case, might be good to think about it. So intent should be to enable equitable access and use. I would also say representation. Taking a path that does not end up putting Indian genomes in the global databases is a bad path for India itself. Because which means, so I'll give you another important number. When we sequenced the first 1,000 whole genomes from India at IJIB, we found 15 million new variants, not previously described in databases. That's how much Indian unknown genetic diversity is. In Africa, by sequencing 500, they got, I think, around 10 million, even a bit more diverse than we are. So the fact is that most global genetic databases are white, and there is an inadequate representation of South Asians and Africa. In fact, there is, from a genetic standpoint, Africa is so much more diverse than the rest of the world that it really bears a lot of thinking about. Which, if you think of the history of humanity and migration out of Africa, then spread with one branch going towards Europe, but most of the genomic efforts being concentrated in those countries, all of it will make intuitive sense to you. So how do you practically define solidarity? A collective commitment to carry costs. That's really all it is. You realize that shit will happen as you share data. I can't actually think of a better word than that. And you agree that we will together carry the costs. That's all it is. And this is something that state can do better than others. Carrying the cost is something a state can do better than individuals. So people who are harmed, people who are discriminated against, people whose insurance companies turn down their coverage, well, the state can legislate its way out of the costs. Research biobanks are operationalized examples of data solidarity. UK Biobank is a wonderful case study. Clearly, there is potential for misuse. Clearly, you can get the data. They screen you. They ask you to build, and Mayank, for example, is looking at the architectures they force you to build at your university before you can become a member, before you can touch the data. So it can be done. Now there is going to be a biobank of biobanks. That's also happening. India does not have any proper operational biobank yet, which is a matter that we need to remedy. In fact, even the 1,000 genomes that were sequenced in absence of clear rules are still sitting there, not available to the community. It's something we need to do. But India does have an act. There's a national IBDC, Indian Biological Data Center, IBDC, at RCB in Delhi, that is supposed to take all data coming out of all government-funded projects. But again, the operationalization is still happening. And there is no easy answer to where do you place general health data in this. You really have to look at the type of data that you're talking about and phrase it there. I mean, for example, from your data stripping out your income and your zip code, possibly is no great public health value. But on the other hand, it could if you were looking at socioeconomic discriminators against health. So you have to look at it case by case. And I think a framework of this thinking where investigators defend what they are proposing to do might be a good way forward. And again, every time you ask this question, are mitigation strategies in place? And this can only come through legislation and acts. So very briefly, I will discuss the Indian Digital Personal Data Framework. It is currently in discussion. It has been cleared by the cabinet, but I think it still needs further approvals and discussion in the parliament. Personal data in this act means any data about an individual who is identifiable by or in relation to such data, which means de-identified data is non-private and not covered under the act. Challenge, of course, will be identifiable to what degree, and that's the question I think, Kapitesh, you asked yesterday. And at least some of the computer scientists at Ashoka have framed the question in a slightly different way. Let's assume that from public data, I can say these 100 people are the ones I do not want to insure at all. I can calculate this Subhashish's framing, right? I can calculate for any given person without identifying them, the probability of being one of those 100. And I can take a decision whether to insure them or not based on my confidence that they are not in those 100. Also, in a sense, I have already discriminated without actually identifying the person exactly. So which means that even our act, to be truly complete in the holistic sense of what this should mean, must accompany insurability and non-discrimination and a variety of other things. Simply stating that is probably not enough. Number two, the act only applies to automated processing, which again is a problem, the way I see it. Informed consent is emphasized, thankfully, because consent is not the same thing as informed consent. All of you know that from the wonderful talk yesterday. And proper documentation of what information was given is also required, which is good. The deemed consent concept is introduced. In all the cases I've listed here, consent is deemed to have been provided. No consent is required. And you can see medical threat to individuals or someone else or public health threat are all covered. Public interest is covered. This is the most interesting one. Fair and reasonable, I've copied these exactly, so the language is the same as that in the Act. Fair and reasonable purpose where the legitimate interest of the data fiduciary outweigh adverse effect on the rights of the data principal. Data principal is the person, data fiduciary could be the hospital or anybody else. This is kind of interesting. This one is going to be hard to properly define fair and reasonable purposes and legitimate interests. Up to here, I think is undisputable. Public health and all that is well known. Children are very strongly protected, which is a very good step. And this last line was quite interesting to me. Any tracking or behavior monitoring of children or targeted advertising directed at them, it is a simply banned purpose. You cannot use children's data or targeted advertising. So that was forward-looking. And of course, the Spider-Man line, power and responsibility. A data protection officer will be mandatory for any organization that is sufficient in scale and importance. And this is important. And it will be good to see us developing a culture in which we actually train data officers who understand what all this is about. Rights of individuals include right to information about the personal data, right to correction and erasure of personal data. These two are important, also very tough. And this is where I said digital determinants will come into place. Many people will have these rights, but no means to exercise them, which is important. And of course, right, these are relevant. The Data Protection Board, headed by a CEO in India, will be responsible for all of this. It will be a civil procedure. So it will be almost like a civil court, not a criminal court. It will be like a civil court. So that's again important. Foreign collaborations in which data is transferred outside India are not touched upon, except as a case-by-case basis. So which means any collaboration outside India, where you're going to looking at transferring data, needs to be still go through a few regulations that don't actually touch exactly. So with that, I think I'll open it up to discussion in the remaining time that is there. Many questions are as opaque to me as to anybody else. The best I can do is let's discuss it out together. Thank you.
Thank you very much, Anurag. And yeah, I think there's a lot of food for thought. So any discussion, anybody want to start?
Yeah.
So I don't know if I can articulate this question correctly, but what is your opinion on, so informed consent is important, it's known, but looking at the very interesting social dynamics we have and information exhaustion that we suffer from very quickly. So is opt-out approach with a good regulatory mechanism a better way to proceed forward?
It's a great question. And in yesterday's talk by Dr. Tiffin, you saw the example that she gave. Give a huge amount of information, then say yes or no, or take it section-wise. To be honest, that information overload and exhaustion is a genuine problem, and that's probably exactly why you designed these things the way that you did. So let people be given bite-sized chunks of information with their opinions at the end of each chunk, and think of more practical ways of doing it. Opt-out would certainly apply to certain types of information that have low risk. So again, if you were to imagine that framework of low risk and high value, you could say low risk, high value, opt-out. High value, high risk, only opt-in. High risk, low value, a massive burden of something before you agree to share, including compensation, everything else being covered. And yeah, I mean, that's how I would look at it. I mean, that's kind of why that framework of risk versus benefit was being brought up by Barbara.
Thank you.
Anyone else?
Yeah, two questions, Anurag.
Yeah.
One is you mentioned that the state could take responsibilities for some of these. So one arises certainly in the Indian context about state capacity. mean, there are many areas where the state is actually retreating. And the state needs to make a specific commitment to this, put in the finances, put in the effort involved in that. The second is sort of follow-up to that. One is that the state's relationship to privacy has not been uniformly good. I mean, for example, if you pass through the Digiyatra lines in Delhi right now, you get pushed into the Digiyatra thing without them telling you what it is. Apparently, this information is collected by a private company, not under RTI. So there is no way in which any citizen can actually monitor what's happening to personal data, including your Aadhaar number, including your face recognition. And this seems to be a huge loophole. So, I mean, when the state itself seems uncertain about how it should protect the liberties of citizens and privacy of citizens,
you are spot on. I mean, I honestly cannot possibly agree with you more, which is also why I brought up the idea, the story of the person with the murder is caught. But then again, there are many other things as well. I don't think there will ever be a good answer to that except elect a government that is more committed to the purpose. And that would be an electoral responsibility of the people to think about these things. And again, if you were to think about making people aware, that's where this will boil down to. Because the only way out is by the state. To say that we would not share data again will not occur, because even if to say we will not share data, well, there will be 100 different loopholes by which it is already going. So saying we don't share data penalizes only the probably legal users. The illegal users will build an entire black market on the data anyway. So the only way out is to push the state to do its responsibility while doing this. I mean, again, I haven't ever thought of a solution out of this beyond this.
I mean, the other route is we do have a right to privacy, which the Supreme Court has creatively interpreted in certain contexts, but
so that's what I meant. Your right to privacy, even if the Supreme Court says, in absence of a fast and effective justice system, the illegal routes of your data being used will still remain.
Absolutely.
So the net, if you were to think outcomes as what you want to change, it won't matter.
Yeah.
Sir, you said about the community and their back pain and all. So,
back pain?
Not back pain exactly.
Ataxia.
Ataxia. So, the thing is, even in the insurance policy right now, if you are going for a 20 to 30 or 40 years old, their insurance amount is less. And after that, their insurance amount is more because the company wants to profit out of it. Suppose if you are saying a certain group of people will have a high probability of getting some disease, then the insurance policy also working on the AA and all the stuff. So they can also say that if you are from this community, then your amount of investment should be high, should be low. So on what restrictions we can give like up to the equality of all? Because
it's a great question. So let me speak about some general principles that have been tested and what the findings are. So age-related increases in insurance rates is considered ethical. Reason is that ultimately you need to create a viable, sustainable system of insuring. If you're seeking private insurance, using age as an index of assessing rates is non-discriminatory. Not offering insurance or offering exorbitant insurance rates is discriminatory. So this problem occurred in America. Let me actually take a step back. Where the government provides free, high-quality healthcare for all citizens, many of these questions actually become meaningless. The correct solution is always a public healthcare system of high quality, free or minimal cost to citizens. Now that removed and out of its way, let's come back to private sector. So what they did in the Healthcare Act under Barack Obama was to make sure that there is a cap on the amount of insurance that can be charged and increase the rates at the bottom of the pyramid of low risk to make sure the system stays financially viable. So effectively, the young people subsidized the insurance rates of the elderly, which is okay. You're normalizing a bit. However, a question came, would a higher rate for a smoker be discriminatory? It was felt not, because smoking is a personal habit that people can control, and it is okay to charge people more if they smoke. Of course, smokers may not agree with me on this, but it was felt to be okay. But you change the same question to should you charge higher to a person living in a heavily polluted city like Delhi, who is the equivalent of smoking? No, it is not okay. It is not a choice they can really make. So this is the kind of thinking that typically goes behind what is fair and what is unfair. Something in people's control, you can introduce something to charge for it. Something that is essential for viability is also important. Community-based discrimination is absolutely not on, but you could argue gender-based discrimination already occurs against males, for example. So males may have higher insurance rates, although it's always struck me as not exactly because, because of pregnancy and so on, the total healthcare demands might be higher on one side, but males typically have lower longevity and so on. So it's quite interesting. Many of these things are considered okay, many of these things aren't. The right answer to my mind is have these as open public discussions, get people's views, let people defend, and then let the state figure out the legislative process regarding what constitutes discriminatory raising of rates and what constitutes non-discriminatory. Because there are many directions this can go. And clearly the use of genetics to raise rates is not on.
Can you wait for the mic?
So this was also taken as a case-to-case basis for India, where certain diseases like rare disorders, the insurance companies were discriminating against, and then the court had to rule that it has to be brought under the mandate of insurance. So maybe getting transparency onto how premium is calculated would possibly help.
And these things are very troublesome. Can you believe in America to date, nobody can get a transparent declaration on the costs of healthcare procedures that are under insurance? It is covered under the proprietary information. So if somebody else got to know how much we charge for this procedure, our business would be hurt, so nobody is disclosing the information. So all kinds of pushes and pulls will come. And I still think, like I said, the real proper solution is a high quality publicly funded healthcare system that removes most of these issues, but that won't be there anywhere. In India, about 70% of healthcare is private and out of pocket.
Yeah, you talked about what's important for people for health. You talked about mental health, sexual health, fitness, and then identity. I would like to know mental health. We know how people are trying to capture that, but like how you think identity should be captured to cater to.
Why I should have been more clear on the word identity. What they meant were things like gender identity, not fitting, for example, into a perceived thing. Examples that were given is in a digital world, which is anonymous. You can have a sense of identity very different from real life. So all these topics were important. I mean, I guess you'd have to be immersed in a digital world like a young person today might be to fully understand how important that is in terms of a concern. And privacy. So for example, privacy in the context of keeping their digital persona separated from their physical persona, so they could choose who they wanted to be. It was a very complicated, lots of answers I don't fully remember, but this is my memory on the identity. It was particularly gender identity.
So I work at the Bangalore Science and Technology Cluster, which is an initiative of Office of PSA. So one of the biggest themes is health here. So we do have this consortium-based projects coming up, but the members consist of private and public and academics and hospitals, even startups and NGOs. So data sharing is always a problem there. And should we be encouraging them to have data sharing guidelines in their own institutions, or should we have a common data sharing guidelines which can help this consortium to take these things forward?
It's a great question. To my mind, a different solution is a side solution. when people think their data is so valuable that others will hang out and give them something for it, it'll be difficult. As more and more relevant data of similar types becomes publicly available or through collaboration with others, organizations change behavior. So for example, let's say I work with 3 different private organizations in health. One of them says, fine, let's start sharing data, and outputs start coming out. Now suddenly organization 1 and 2 that were previously extremely possessive and difficult suddenly change the tune. So as data becomes more easily available, more and more people decide to jump onto the same bandwagon, because ultimately humans are the same everywhere. So you will see this for LLMs also, right? I mean, now that Meta has made a publicly available LLM, you might see very different way of thinking about other people who wanted to keep their code proprietary or not. So as the open data movement gathers strength, many of these problems will solve themselves. And to my mind, strengthening the open data movement with the data solidarity purpose, clearly articulated, more biobanks, better access, very streamlined professional architectures, the problem resolves. That doesn't actually answer your question, but tells you a side path by which we can get the desired results.
On that line, the Data Privacy Act, I forget what the name was, but it said it does not apply to de-identified data. So how do you know that a data set has been properly de-identified and there is
Great question.
And I mean, that's something that Nikki also talked about yesterday. Yeah.
It is exactly the question I would ask on this act. How does one know? What is the definition? And like I said, the example I'm borrowing from Subhashish Banerjee, even after de-identification, it can still be misused. You have to act on the other side, not speak so much on data itself. It is the purpose and the harm.
Yes, one more question.
So have people considered encrypting data with something, or it's already there?
So again, it goes back to the lock analogy I was giving. Encryption as a mechanism for protecting your data will work, but probably will not work as well against malactors anyway. I personally think the better way out is along the directions of make it more easy to get and use, but very strong penalties with a fast acting system, which Gautam pointed out is not there in terms of misuse. So a fast acting efficient system that cracks down on you for misuse, but otherwise easy to use is a better way. So lots of encryptors in this space. So one of my colleagues at Ashoka is coming out with a very interesting model that adds noise and yet allows everything to remain okay. So those are the other ways of doing it. But encryption, to my mind, is not amongst the top solutions over here. So adding some kind of noise that does not affect your statistical calculations, but allows use, or simply federated architectures and so on, is all fine. And actually the two can be combined, they're not exclusive of each other.
Very nice talk, thank you. So you mentioned that knowing your own genome is of no use. Well, without
in absence of a reference genome.
So a reference we have, but right?
My point is the reference also came from people who donated their data.
Correct, exactly. And so knowing my genome, I can at least screen for mutations that are well established.
So but what I meant was something else. So I can see where you're going. I said my genome in isolation of any other genome is meaningless.
Correct.
And my expectation is that that reference genome exists and the meanings of the mutations exist, which actually comes from other people's data.
Exactly. So the mutations that we know currently are all from the West.
Yes.
And so to know, so even just the genomes in isolation, genomes of other people are not enough, but we also need to know the phenotype.
Yes.
Because if you're looking for a specific, let's say, cancer mutation or some screening for that. So just So I'm going back to the question of your 1,000 genomes. Why are they not available if there's no phenotype associated with it?
Because of the consent architectures associated with in the genome project. So all genome projects always give people the right to remove their data if possible. Now, how do you do this together? If I were to allow somebody to download it, then is it incompatible with the commitment I made to them in the ethical consent that we will remove your data? So if it has to be truly removed and erased, it can't be downloadable. So a architecture that allows a federated system to act on it, get whatever is required. So if on my institute's website, you wanted to do anything that gives you allele frequencies, you can do it even today. And these were normal people, so there was no particular phenotype.
Right.
But if they were diseased, you would simply link the phenotype to allele frequencies, and for any position in the genome, without downloading the sequence, you could get allele frequencies. Because in the end, all genetic tests or associations only do that.
Exactly, because I think you're lacking GWAS studies.
So we didn't have a phenotype in the sense that these are all normal people, but allele frequency extraction for any label on the phenotype suffices for 95% of the users people have in their mind for genomes, and allowing people to download it puts us in conflict with that line in the consent. And that's a mandatory line. So if you go by the global agreement on how genomic data should be handled, that line is mandatory.
Okay, so I think we are out of time, but let's thank Anurag again.